So I'm going to tell you about what can be done today in terms of therapy of the different CDG forms. And CDG1B is a disorder where you have diarrhea as a symptom, hypoglycemia, you have no neurological symptoms, but nevertheless it can be a severe disease where you die from. And the problem is here. You have to incorporate these mannoses into the glycoproteins, and in order to do that, you have to activate them. And the defect of CDG1B is here, that you cannot synthesize mannose 6-phosphate from here anymore, but if you give a lot of mannose from outside, then you can synthesize mannose 6-phosphate again, and you can correct the problem. Surprisingly, that takes quite a lot of time. If you start treatment with mannose, here you can see this is a hypoglycosylation, transferrin, just another electrophoresis technique as you have seen before. A month later, nothing has happened, although they should act immediately. In PGM1 deficiency, it acts immediately. If you give them galactose and test 2 weeks later, you already see the effect. Here you don't. And it takes a year until you have full normalization of the glycosylation, but that's what you get. You get complete normalization of the CDG phenotype. It's a very effective dietary therapy. And, well, initially we thought that happens only once, but then this patient came along. This patient is also a very rare subtype of the CDG disease, where you have a problem in the leukocytes. This child stayed in the hospital after birth for more than 1 year, because every time he developed fever. And when you look at the leukocytes in the blood, that's where they normally should be. And then these leukocytes during the first year of life, here you can see, they are very, very much elevated. And the reason for that are, again, sugars. At the surface of the leukocytes, the blood cells that are responsible for fighting bacterial infections, at the surface you have a sugar coat. And in this sugar coat you have another sugar here, it's called fucose. And this fucose is missing in the patient. So here we have not a problem with the mannose, but with the fucose. And then the sugar coat is gone. And then these neutrophils, the leukocytes, cannot go into the tissue anymore because they lose the capability to do that. So that's you have seen that several times, how complex the biosynthesis this problem is. It's just here in the end of the biosynthesis, here you have to add fucose to some glycoproteins, and that has to be imported into the organelle where this is done. And this transporter for fucose is defective. And here again, when you give fucose as a dietary supplement to patients with this kind of CDG, what happens? You can see here. We started with the fucose therapy here, so just before, he has this severely elevated leukocytes. And just after beginning the fucose therapy, the sugar coat reappears, the neutrophils work again, and he has no problems with fever anymore. So the second form of CDG disease that can be treated with a sugar supplement in the diet. And you have heard of this new disease, PGM1 deficiency, that was discovered by Laura and Stefan in my group sitting there in the back, and at the same time by Dirk Lefeber's group. And there you have this problem that you cannot degrade the glycogen. And then you have this accumulation here of this sugar, and you have not enough galactose for the glycosylation. And here if you add galactose to the diet, you have a very effective correction of the hypoglycosylation problem. So now we have 3 admittedly pretty rare subtypes of CDG that can be treated either with mannose or with fucose or with galactose. So we have different sugar pills if you wish. But what about the most frequent CDG, CDG1A? And you know, people have tried for a long time because it's also a problem in the metabolism of mannose. The problem in CDG1A is just one enzymatic step further than in CDG1B. But what happens here, if you give external mannose, you make mannose 6-phosphate, but this guy is not working and you cannot go on further. So theoretically, that should not work if you give mannose in this situation. But Christian and also Hutt have shown decades ago that if you add mannose to fibroblasts, to cells of children with this disorder, the biochemical problem goes away immediately. There's no hypoglycosylation anymore. So many people have tried to treat. Okay. I said Hutt and Christian. I make that. All right, I said Christian and Hutt, so I say now Hutt and Christian. Okay. Okay. So here's an example of what happens. You can see here the CDG1 pattern in the CDG1A child. And then this child was treated for more than a year with mannose. And you see we took repetitive samples from the patient, analyzed them side by side. There's no change. If you look at proteins that are synthesized from the brain, that was equally disappointing. If you do that after 2 years of mannose therapy, you look at a special protein called beta trace protein before and after therapy, it's not much of a change. So that was very disappointing. And one of the major reasons for that was that the concentrations of mannose you get in the blood of these children is by far not high enough. It's not as high as the amount that you need in the cell culture. So the next step in order to develop a therapy for CDG1A was to give the mannose 1-phosphate directly. It's a disease where you cannot synthesize the mannose 1-phosphate from mannose 6-phosphate. So why not give the mannose 1-phosphate directly? The reason is why the cells will not take that up. It's a polar substance, and the cells are unable to take this up. So the next step was to make compounds of mannose 1-phosphate where all this hydrophilic residues in the molecule are covered so that the cell will be able to take that up. And that actually worked pretty well. There were several compounds generated that would do this and will correct the biochemical phenotype. But it's completely impractical for clinical use. It's very expensive, it's partially toxic to take the substances, nothing you can really use. So in order to understand the next graphs, I have to show you once more this slide where you see the normal pattern when you are healthy and the CDG1 pattern where instead of 2 glycans on the transferrin you have only 1, this band, or only or none here. And if you want to see whether there's an effect, what you can do is you can make a therapy, take some blood samples from the patients from time to time, and then quantify how much normal transferrin do you have with the glycans on it, and how much of the transferrins do you have that are abnormally glycosylated. So if you do that, and if you look at that over time, if you have a therapy that will have no effect, then it will look like this. You have the normal transferrin, which is called tetracyclotransferrin. That's always in red. The red is the normal transferrin. You have only about 50% in CDG1A. And you have the abnormally glycosylated transferrin here in green. If you see this in different samples, you have no effect. If you see something like this, you start with a therapy and then the normal transferrin gets more and the abnormal transferrin gets less. That's pretty good. Then you have a therapeutic effect and you have that what you look for. So when we saw that the blood concentrations of mannose were not high enough in CDG1A children under mannose therapy, there was a professor in the pharmacology department in Dallas, Mark Lehrman, who published 2 papers. The idea of the first paper was, if you give a drug that will make it easier for the cells to take up the mannose, then maybe you can have lower mannose concentrations that are already enough to correct the hypoglycosylation in cells. And he could show that that worked. If he used a drug called metformin, which is also used to treat diabetes, then he could show that he needed lower concentrations of mannose in order to reach the same effect that he would get if he would not use the drug. The second idea was equally good. If you make 50 transferrin molecules and you need 2 sugar chains for each of them, you need 100 sugar chains. But if you can only make 50 because you have a problem in your cell, then obviously you have a problem. Then you get a CDG disease. And if you cannot correct this problem, that you have only 50 glycans made, what you can also do is, or what you can also think about is, if you make fewer proteins, if you make only 25 proteins, then the 50 sugar chains will be enough. And then you have normal glycosylation again. That's a concept he called translational balancing. And it's just simple, if you don't have enough sugars, make fewer proteins. All right. So when this paper came out, we thought it might be worth to test whether this also has a clinical effect, since one of the substances he used was already in clinical use, and metformin, as I said, was already used for treating diabetes. So what you can see here is what happened. This is 2009, this is 2011. So these are 2.5, nearly 3 years. And we first put the children on mannose, and on more mannose than before. I told you mannose makes diarrhea. You have to very, very slowly increase the dose of mannose in order to get a better tolerance for the sugar. And then at a certain point, we added one of the drugs, either metformin or this other substance called disulfiram. And then we took blood samples from time to time. Of course, we looked at the children, whether they improved or not, or what happened to them, whether there would be side effects. And then we just quantified the amounts of transferrin. So these lines here are not important. That's why they have this light color. So now we look at the hypoglycosylated transferrin. That's the bad transferrin. You start up with about 50%, and after nearly 3 years of treatment, you have only 20% left. So that's very good. That's a considerable improvement. And that's absolutely in contrast to all the many children we have treated with mannose before, where we saw no change whatsoever. Look at the tetracyclotransferrin. That's a good transferrin. The good transferrin was 40% when we started and was nearly 70% after 3 years of treatment. So that's a treatment effect of what you do here. And then you can look at other glycoproteins. You know that coagulation, blood coagulation factors are often not normal. This here is antithrombin 3. You can also see as the activity is rising, it's getting more function because it's better glycosylated. And if you plot that all together, you see it looks like this. There's a considerable amount of time, and that's even much longer than in CDG1B, where nothing happens. So if you just do a short-term mannose treatment of half a year or so, you will see nothing. But if you do that for a prolonged time, about 1.5 years later, then you start, then you see that these curves will go apart and that you will have a treatment effect. And if you look at what happens with metformin, it looks pretty similar. So we have done that for several years. We started here in 2007 with the one patient, and in 2009 with the other patient. And this is just the update of the plots up to July 2013, so now. And you can see there's still improvement. And the tetracyclotransferrin has improved so much at 85% in our quantification method. We have a normal, that's what we have in normal healthy people. 85% or more. And we have already reached 80% of tetracyclotransferrin in these children. So this is a very good treatment effect. So CDG1A, that's my message, it can be influenced. The glycosylation can be improved by a dietary and maybe additional, by dietary intervention and maybe an additional treatment. At this point, I'm not sure whether the disulfiram and the metformin really have an effect. Because these curves look so similar that it could be just a prolonged mannose treatment by itself. These are just 2 children. And of course, what you have to do now is to test that in more children. And in order to find out whether this is feasible at all, we asked in Germany the families what the weight of the children would be, because we give 2 grams of mannose per kilogram body weight a day. And mannose, some of you might have used that for the children. It's pretty expensive. It's nearly $1 or €1 per gram. So the average weight of the children or the patients in Germany was 37 kilograms. And then we calculated if you use 2 grams per kilogram body weight, if we do that for 2 years, and if we include 30 patients, so that we can treat 10 of them just with mannose, 10 of them with mannose and metformin, and 10 of them with mannose and disulfiram, what we would need is 1,600,000 grams of mannose, which is close to 1.5 million euro you would just need for the simple sugar. So at this point, of course, we were discouraged again. But fortunately, we have found a sponsor who is going to supply all this amount of mannose. And we just need additional funding to get this study started. So pretty soon, there will be a study where we again systematically investigate mannose in a larger cohort of children with CDG1A. Okay, now I'm at the end. And well, you can ask questions if you want.